Scalp. Today we'll be discussing the scalp under the following headings. First, we'll have a brief introduction about the scalp, following which we'll be discussing the different layers of the scalp, then the arterial supply, the venous drainage, the nerve supply, and finally the clinical correlation. Now, what is the scalp? The term scalp refers to the soft tissues covering the vault of the skull. The skull, we know, is the bony structure in the region of the head, and the vault of the skull is this region right over here. And all the tissues that cover this vault of the skull is what we call the scalp. Next, talking about the extent of the scalp. It has an anterior limit, a posterior limit, and lateral limits on either side. The anterior limit over here is the superciliary arch, right over here, which is nothing but the region of the eyebrows. Next, the posterior limit is the superior nuchal line, which is a feature of the posterior aspect of the skull. Next, the lateral limit on either side is the superior temporal line, right over here, on either side. So that's that about the extent. Next, we'll be talking about the layers of the scalp. Now, there are a total of 5 layers of the scalp, which can be remembered by an easy mnemonic, the word scalp itself. Now, let's look at this one by one. S stands for skin, which is the first layer of the scalp. The thin layer right over here is the skin. Next, we have C, which stands for connective tissue, the layer right over here. Then we have the aponeurotic layer or the aponeurosis, which is this green structure that you see right over here. Then we have L, which stands for loose areolar tissue, which is this white region right over here, loose areolar tissue. And then we have the final layer, which is the pericranium, which is this thin line right over here, over the bone, pericranium. So these are the 5 layers, and we'll be talking about them in detail. So first we have the skin. The skin over the scalp is thick and hairy, and it has all these characteristic features of the skin that are hair follicles. We said the skin was hairy, so there are hair follicles, and there are sebaceous glands, and then there are sweat glands. And due to the presence of these sebaceous glands, there is an increased probability of sebaceous cysts occurring in this particular layer of the skin. That is the clinical feature of this particular layer. So that's about skin. Next we have C, which stands for connective tissue, which is this layer right over here. The connective tissue layer is nothing but the superficial fascia that we see under the skin. It is the second layer, and it connects the skin, which is the first layer, to the underlying aponeurotic layer, which is the third layer. It connects the skin to the aponeurotic layer. It firmly binds the two. Next, talking about the features, you can see there are numerous fibrous septa in this region, the black separations right here. And these fibrous septa divide this whole layer into many small packets or pockets containing lobules or fat. Next important feature regarding this layer is the presence of blood vessels and nerves. You can see cross sections of arteries and veins and nerves in this region. So this is the vascular layer of the scalp. So that is the connective tissue. Next, talking about the aponeurotic layer or the aponeurosis, this green structure right over here. So the main feature of this layer is the occipital frontalis muscle, as you can see in the figure on the right. The muscle of the scalp is the occipital frontalis. It has frontal bellies and occipital bellies. The frontal bellies are the ones lying over the frontal bone. They are longer, wider, and more close to one another. And then we have the occipital bellies in the back, right over the occipital bones on the posterior aspect. And these are shorter and also a bit separate from one another. There's a gap in between the two bellies, occipital bellies. So these are the muscle bellies. And we have the aponeurosis, the green structure that is seen in the figure, which is nothing but the fibrous layer which connects the bellies of the muscle. This is also called the gallia aponeurotica. Next, we talk about the anteroposterior tension. So this aponeurosis right over here is under anteroposterior tension. The muscle right over here, you can see anteroposterior lines. That is due to the tension exerted by the occipital frontalis fibers, which causes this tension. So the importance of this tension is that whenever there is a wound in the anteroposterior direction, it does not gape, that is, it does not form a gap. Whereas if there is a transverse wound in this region, it gapes. There is a formation of a gap, which is due to the tension, anteroposterior tension in this region. So So that is the importance of the aponeurotic layer. Next, we'll be talking about loose areolar tissue, which is the fourth layer of the scalp. It's the white region right over here. It is nothing but loose connective tissue. There are no major structures in this region, and it is very loosely connected, and it acts as a natural plane of cleavage. The first three layers are firmly bound to one another, and they form what is called the scalp proper. And the scalp proper can be avulsed, or that is, it can be separated from the underlying loose areolar tissue. That's what we mean by natural plane of cleavage. Next is the presence of emissary veins. Can you see that there are emissary veins that connect the veins of the second layer, connective tissue layer, to the intracranial dural sinuses within the brain. So these emissary veins traverse the loose areolar tissue. Next is the final layer, which is the pericranium. The pericranium is nothing but the periosteum of the skull bone. It has loose attachment to the bone underneath, except at certain regions, the region of the sutural membranes. So we know that the bones of the skull are connected to one another by the means of sutures. And at the region of these sutures, the periosteum is firmly bound to the bone. Next, talking about the nerve supply. So whenever we discuss the nerve supply, we have to talk about both sensory nerves and motor nerves, if applicable. So first, let's talk about the sensory nerves. There are 8 sensory nerves on either side. Let's look at them one by one. There are 4 in front of the auricle. This right here is the auricle or the ear. In front of them, we have supratrochlear nerve, supraorbital nerve, zygomaticotemporal nerve, and auriculotemporal nerve. All these 4 nerves arise from different branches of the trigeminal nerve, which is the 5th cranial nerve. Next, we have the 4 nerves arising posterior to the auricle. We have the great auricular nerve, the lesser occipital nerve, the greater occipital nerve, and the third occipital nerve. All these nerves arise from the cervical nerve, C2 or C3 or both. So that's about the sensory nerves. Next, moving to the motor nerves. The motor nerves are the nerves which supply the muscle of the region. Here, the occipitofrontalis muscle. The occipitofrontalis muscle has both frontal bellies and posteriorly the occipital bellies. The frontal bellies are supplied by the temporal branch of the facial nerve, and the occipital bellies are supplied by the posterior auricular branch of the facial nerve. Facial nerve, which is the cranial nerve number 7. Next, talking about arterial supply. The scalp has an extensive arterial supply. On either side, there are 5 arteries. Let's look at these one by one. First, we have the supratrochlear artery, then the supraorbital artery, then the superficial temporal artery, the posterior auricular artery, and the occipital artery. There are 3 in front of the auricle, and there are 2 behind the auricle. Then, next thing we have to note is the origin of these arteries. The first 2, supratrochlear artery and the supraorbital artery, arise from the internal carotid artery. Next, the next 3, the superficial temporal artery, the posterior auricular artery, and the occipital artery, arise from the external carotid artery. Next, we have to note the extensive anastomosis in this region. We see there is an extensive connection between arteries of both sides. Moreover, there is extensive connection between the arteries of one side themselves. So we can see there is an anastomosis between the branches of the ICA, internal carotid artery, and ECA, external carotid artery, on either side. So due to this extensive vascularity, we see that scalp wounds bleed profusely, but they heal quickly for the same reason. Next, talking about the venous drainage. Now, when we talk about the venous drainage, we must keep in mind this same figure itself, because the veins of the scalp have run alongside the arteries of the scalp and have the same name as them. So we have a supratrochlear vein, a supraorbital vein, a superficial temporal vein, a posterior auricular vein, and an occipital vein. Now let's discuss about the cause of these veins. First, we have the supratrochlear vein and the supraorbital vein. Here they are, supraorbital and supratrochlear. They arise from the anterior aspect, and they join to form the angular vein. The angular vein we see continues to form the facial vein. So that is the first and second veins we talked about. Next, we have the third vein, superficial temporal vein, which arises in front of the auricle. It joins with the maxillary vein right here and forms the retromandibular vein, and the retromandibular vein in turn divides into 2. anterior division and a posterior division. The anterior division of the retromandibular vein joins with the facial vein that we discussed before to form what is called the common facial vein. The common facial vein ultimately drains into the internal jugular vein. That is the first three veins. Then we have the fourth vein, which is the posterior auricular vein. The posterior auricular vein arises behind the auricle and it goes down below to join with the posterior division of the retromandibular vein and forms the external jugular vein which drains into the subclavian vein. So that is about the venous drainage of the scalp. Next, let's talk about the clinical correlation. First, we'll be discussing about cephalhematoma. A hematoma is a collection of blood. Cephalhematoma is a subperiosteal collection of blood. Now, to understand this condition, let's recall the 5 layers of the scalp. The 5th layer is the periosteum. 5th layer, periosteum, under which we have the bone, the skull. So, cephalhematoma is a subperiosteal collection of blood. Now, look at this figure on the right. There is a periosteum covering the bone, and below it we have the collection of blood. So, when we discussed the periosteum, we said that they are connected to one another. They are connected to the bone below only at the sutural membranes. They are loosely attached to the bone in all other areas. So because of this connection to the sutural membranes, whenever there is a periosteal collection, it acquires the shape of the bone. So if there is some injury in the parietal bone region, there will be a subperiosteal collection of blood which arises in this region, and it acquires the shape of the parietal bone. It is a cephalhematoma. Next we have Caput Succedaneum. So cephalhematoma was a subperiosteal layer of blood. Caput Succedaneum is a subcutaneous edema, subcutaneous, so it is below the skin, the first layer, skin. So it will be above the periosteum. So there is no connection of skin to the sutural membrane. So whenever there is Caput Succedaneum, it crosses the suture lines. It is not restricted by these suture lines and it does not acquire the shape of any bone in this region. It is just a swelling, generalized swelling in that area. See this picture on the left. It is a big swelling right over there. So when does Caput Succedaneum occur? It occurs over the presenting part of the fetus at delivery. So whenever a baby is born, normally, vaginal delivery, the cephalic presentation or the head presentation is the normal presentation. So whenever the head is delivered, there may be a constriction in this particular region. The constriction causes an interference of venous return from the top region to the downward flow. And due to this interference, there is the swelling and that is the Caput Succedaneum. So that is Caput Succedaneum, and we come to an end. Thank you.